Hello.
Hi.
Hello.
Good morning.
Welcome.
Welcome.
Welcome to UEG Week Virtual 2021.
Whatever your level of expertise, you will find the best and latest updates on UEG Week Virtual.
I wish you those days full of interesting, diverse and creative content.
I count on your contribution and I thank you.
Viel Freude, ingest the best.
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 Keywordは ingest the best です。
Get ready to ingest the best.
Ingest the best.
Ingest the best.
Well, hello everyone, and good morning again from our live TV studio here in Vienna for UEG Week. And I am really excited about this session, UEG Week Digested, because I hope you've been enjoying the program so far. But if perhaps you've missed some sessions or heard that something was particularly interesting, this session we're going to go over everything that happened yesterday with our multidisciplinary team. These are the creme de la creme, our faculty this morning. They'll explore and bring out some of those highlights, which you can hear them discuss, but also watch back in the missed a session button. So let's bring in our faculty, shall we? They are Professor Herbert Thielk, who's of course chair of the scientific committee, Professor Magnus Simrin, UEG Secretary General, UEG Journal Editor-in-Chief, Professor Joost Drent, Professor Mario Diniz Ribeiro, who's our UEG Council member, and from the scientific committee, Professor Britta Sigmund. How are you all? Good?
Very good.
You all look very fresh. We were out for dinner last night and you all look very fresh considering how late you were out. How was your first day, Herbert? Was it good?
It was a wonderful day. I mean, we had great contributions, great, wonderful late breakers. So overall, it was also very well received. Fantastic day.
Yeah, I was just in the TV studio, and I have to say, I found it really interesting. We had some really nice, different types of talks, and I learned quite a bit. What are we doing now? What's this session about?
Well, this is wrap up the highlights from yesterday, so a real digestion, and I think that's nice because within an hour we can see. Of course, it's very personal, but we see some highlights from yesterday.
And why did you pick these guys?
Well,
for this
is a world-class group of experts. And they've been also chosen because they know how UEG works. So it's, I think, the perfect group.
Very good.
To discuss.
Mario, we had a great session yesterday. I learned a huge amount about endoscopy, but that was just one small feature. Can you tell me a little bit about the program of the endoscopy program for UEG? Because we have a lot of endoscopists, I would imagine, joining us this morning. Good morning to you all.
Yeah, that's interesting. Of course, I will allude to what happened yesterday, but referring to the entire program, my congratulations to Herbert and to the scientific committee that during the years we have been trying to, not push is not the right word, but to introduce endoscopy within the other disciplines that is, UEG Week is all about. So endoscopy is well scattered during in the program, from sessions alluding to training, to ergonomics, to sedation, to disinfection, and of course the live demo on Tuesday.
Yes, a live demo of endoscopy from Prague. As an outsider, Mario, how does this work? The patient knows this is happening, right?
Of course. No, yeah, of course. But that's actually a very important question. We recently updated the ESG, the European Society of Gastrointestinal Endoscopy, that is somehow responsible for this day during the years. And we have revised it and updated the guidelines. And there is a patient advocate that assures that everything is done according to what is expected by the patient. And the patient, of course, accepts to participate in an educational event, because it's mostly to show it's a unique way of showing these kind of things by local doctors. Most of the faculty will be coming from Prague, from Thomas Uschel, led by him and by Helmut, that is the current president of ESG, and also we will try to manage the 16 or 18 patients that will be scheduled for Tuesday.
And a great learning opportunity that endoscopy stream tomorrow. So take me through your highlights, if you will, Mario. What did you like from yesterday?
Well, yeah, I was supposed to highlight the endoscopy and the upper GI fields, and actually I will speak just a little bit about endoscopy. So I think the upper GI is, well, my baby, and I think it's a perfect field where comprehensively we can show the role of endoscopy. So briefly, I will allude to 3 topics: dyspepsia on one side and individualized assessment of those kind of patients, non-invasive assessment of the upper GI, and finally, of course, AI and colonoscopy and how that can affect our practice. So there were two or three lectures in the field of dyspepsia that I would like to summarize. One is the one from Alexander Ford that went through his entire career on systematic reviews assessing the potential role of H. pylori. And H. pylori is very important to our community. It's the main infection probably in our body and related to gastric cancer. So he introduced that as the main strategy nowadays, except for the individualized assessment of each patient and his symptoms or her symptoms. Then De Wit from the Netherlands assess exactly the opposite of my summary. That is when not to scope or when to scope in a dyspeptic patient. And finally, Pedro Nunes from Porto, he addressed on a very nice lecture the potential for individualized screening for upper GI cancer. So upper GI cancer is still, let's say, a problem in Europe and worldwide because we don't care too much about upper GI.
If you watched these sessions, by the way, what are your comments? If you have questions for our faculty, this is a discussion. Please do use the Q&A tool. What else did you like, Mark?
Yeah, and individualized care of these patients, and living a pandemia, it's a nice bridge to 3 abstracts, actually. So we were asked to summarize the invited lectures that Herbert and the scientific committee planned, but of course we have the originals coming from our community. And there are 2 coming from Rebecca Fitzgerald Group and Massimiliano Di Pietro, assessing the role of cytosponge. That is a non-invasive assessment or screening procedures for the presence of Barrett's and dysplasia. And they show that it could be used to allocate patients to different surveillance. And this is interesting because it was used by another group in London during the pandemia to manage and to reallocate and to do not do immediately endoscopy when it's what is proposed. So
actually freed up resources when they were most needed. Wow.
And more, I think we will see that those kind of markers happening in the field of gastroenterology. That is, of course, endoscopy is our, let's say, our interventional arm. But on the other side, you should do less is more and more in endoscopy. So do less is do more. And finally, that is quite of interest for me. It's that you don't have only Barrett's in the upper GI. You also have you have intestinal metaplasia in the stomach, and that's the main marker for risk for gastric cancer. And Rebecca's group also showed in a post-hoc analysis that it can detect some patients that harbor a risk for gastric cancer. So the false positive of intestinal metaplasia for Barrett's could mean a risk for cancer. So this is quite interesting because if you think along what I've been saying about dyspepsia, individualized cares, and also individualized assessment for cancer, you could eventually think about non-invasiveness test before endoscopy and before a screening or a managing of a patient.
Herbert, any questions for Mary?
Well, can you maybe briefly explain this non-invasive test? How is it working?
Yeah, so it's this specific test. It's a pill that the patient swallows with a wire, and then it collects parts of the mucosa, parts of the fluids that are in the esophagus and in the stomach, and then runs a series of biomarkers. In this case, most of all, atypia and P53 were the main markers for cancer.
Yeah. So looking at those data, would you expect this could be the future, that we're doing something like this tomorrow?
Yeah. I'm not sure if that specifically tests, but I think the line of thoughts are good. Our own group is exploring the saliva. There are others exploring the breath. So it makes sense that, or even feces, even though feces for the upper GI it's quite a long way down, but it makes sense. We have been using FIT tests for screening for colon for ages, so it's quite rude. It's just measuring the presence of blood. But I do think that when, well, technologies are available, you could monitorize these kind of things for non-screening, non-invasive approaches to diseases.
This may be a silly question, but are there a lot of ingestible treatment for helping a diagnosis? Are there a lot of these ingestible sensors in use at the moment?
No.
Yeah.
No. And we have kind of disruptive technology during the last years. We have capsule that was thought to try to collect images the same way as common endoscopy, and we have markers for inflammation in other fields. So things are there, but they are still
to get information.
And conceptually, on a diagnostic level, is always interesting because we tend to develop a technology, but we select patients on one side and completely normal on the other side, and then on a clinical basis, we try to use that together with the other information. So this is a perfect bridge for the third topic that I chose, that was AI. And there is a seminal lecture from Cesare yesterday on the role of AI and polyps in the colon. And it's interesting because we recently submitted together a manuscript alluding to the cost effectiveness of detection. And this was shown. It costs, of course, some money, but it saves a lot of money in the care of these patients. But it's still quite, let's say, monotonous, because the colon in this kind of procedure detect the polyp is quite monotonous. So if you think along the line of what we've been saying, AI probably would represent a lot more if it is amalgamated, or if it is aggregated with a priori data, such as what we were saying now. But it's interesting because there were two manuscripts that I had the chance to share yesterday on the late-breaking abstracts, and I think this is also a good message for the community. Of course, until the end, you can submit your abstracts.
Yeah.
That were two abstracts alluding to the low reliability of assessing a fixture that predicts submucosal invasion when you see a polyp, a large polyp that came from Ghent in Belgium, and the second one from Mathieu Pioche in France, where even though there was a presence of this fixture, he embarked on trying to resect the lesion for a diagnostic purpose. And so altogether means that even though AI is not there yet to help us allocating patients to a better treatment, it makes sense to think about it.
So AI ready for prime time? Should we now in our hospitals go for it, or is it a must? Or how long would you believe it could take that we do it all?
Yeah, I think specifically for detection, and I think we all have been worried about adverse events, but missing a lesion, it's a huge adverse event, I would say. And so clearly for detection, I think it's there.
Yeah.
It's there. So I think we are still struggling on what is the ultimate value of introducing that, but more and more, at least for detection in the colon, it's there.
It must have been a great day, because you didn't mention yesterday's case closed session here in the studio, which I thought was absolutely brilliant, where we looked at different types of sort of malignant and non-malignant gastric lesions and trying to figure out which was which. It was a really good session, which you can watch back on the Missed a Session button if you like. Okay, Britta, let's go to you. You've been on the UEG Week Scientific Committee for some time now. Can you share maybe your experiences of what that's been like in the past year, just getting that program together?
I think first of all, one needs to understand the working manner of the scientific committee. And it's like all these more or less important people from the different societies come together and think, well, my field is the most important. And all of a sudden they sit together with the other disciplines and realize they need to either fight very strongly, which is not possible. And at the end of the day, it's a very nice group which peacefully arranges, I think, a very good program. Strong discussion sometimes. What is belonging to lower GI, upper GI? Is endoscopy more important than pathology? So they're really funny discussions and very nice evenings we had. So over the last year, obviously, it was very different. And I miss the discussions, sitting in my office, making staples of different abstracts to different topics and designing sessions. But hopefully next year the committee will be able to discuss in person again. I think that's very important.
Absolutely. Tell me your scientific highlights from yesterday, please.
So I'm covering lower GI, and it's mostly IBD, and I choose primarily original work, and maybe I touch on some of the other topics later. And I start with a topic which has been dominant in all our lives, and this is SARS-CoV-2 vaccination in IBD patients, deciphering the role of anti-TNF antibodies and the effect of anti-TNF antibodies. And it's work done by Hada Klappa-Edelman from Israel, and studying this in roughly 250 patients, showing that by measuring the antibody titers before, in between the first and second vaccination, and 4 weeks after the second vaccination, and vaccination was mRNA vaccination. And they could show that basically all patients became seropositive, which I think is important to know, but still the titer was significantly lower in patients that received TNF antibodies, which I think for all of us is not that surprising. What is interesting, though, is that they didn't see a difference in patients. So it was not the response did not depend on the timing of anti-TNF application, which I think is important, and neither did it on the trough level. So I think that's important. It's important for practice, so you don't need necessarily to advise the patients wait till you have the next vaccination and then go for your TNF shot. So I think that's very helpful. They conclude that you might consider a third vaccination. I think this is up to every country how this will go. Yeah. And I think we need to wait for more data here.
This is interesting. This was a big concern when COVID came around as to how that would affect regular treatments. And now we have the second version of that, which is how the vaccination is going to treat all of the things that are going on.
Right.
Yeah.
The next original work I thought is interesting, although we had previous data on this. It's from the Danish IBD Biobank project, presented by Mirabella Zhu from Johan Burich's group, exploring how patients who got their first biologic, how they do over time. And basically they included a little bit over 400 patients since 2019. And the primary biologic in Denmark is infliximab. So it's basically an infliximab study on biological naive patients, which I think is different, is important. And it's actually difficult to get today a naive cohort. So I think those data are valuable. Remarkably, a third of the patients showed primary resistance, and half of the patients received remission after inductions. And predictors for response were in Crohn's disease, luminal inflammation, and colonic disease, something we knew before, but it's still not really valued to focus on the localization of disease, and concomitant use of immunosuppressive therapy. In ulcerative colitis, it's remarkable. Ulcerative colitis itself is an independent predictor for switch of therapy. So it's probably better to have Crohn's disease than UC when being treated with infliximab. Still, I think those data are really interesting. And last, I'd like to focus basically on two study sets which were presented in 4 presentations here, and all studies have been presented earlier this year at DDW and ECHO, and we are seeing here sub-analysis, but which I think provide interesting data. And the first 2 presentations were focusing on the on the phase 3 studies for upadacitinib, so a JAK1 inhibitor, the U-ACCOMPLISH and the U-ACHIEVE study, and basically evaluating, first of all, the rapidity of response, and this was presented by Ed Loftus from Mayo Clinic, and showing very nicely that you have, even after 2 weeks, you can see a clear response and you can even achieve remission, which then continues to rise over time. But still, as early as 2 weeks after initiating therapy, you can see a response. I think that's always important if you treat patients with this moderate to severe UC, that you know when to expect the response. And the second analysis from those 2 studies was presented by Séverine Vermeer from Leuven, and she focused on patients that had a more difficult history of disease, who either had an inadequate response or were intolerant to biologics or had a loss of response to biologics previously. And the data show very nicely that they equally show a consistent efficacy to UPA treatment in those trials. So I think that's a very important message to know, that you can, patients that previously failed on biological therapy, you can still treat them with UPA. So I think that's important to know for clinical practice. And the second study that has previously been presented this year is the SELECTION trial, so a phase 2b/3 trial, also on ulcerative colitis, focusing on filgotinib, so another JAK1 inhibitor. So JAK1 is obviously the drug of choice here of yesterday, and the first presentation was very similar to the one of Ed Loftus for UPA. So Marc Ferrante here from Leuven focused again on how fast is actually filgotinib achieving clinical response. And in the 200 milligram group of filgo, again, as soon as 2 weeks after starting, you can see a response, and patients that achieved remission showed a better quality of life, which is not that surprising. And the second presentation and analysis on the SELECTION trial was again presented by Séverine, exploring how many patients actually get rid of their steroids over time. And in the first 14 weeks of the trial, the steroids had to be kept stable in order to be able to compare the induction phase. And then there was a defined tapering scheme. And surprisingly, at week 58, the majority of patients in remission had been off steroids for the last 6 months. And I think that's really impressive when it's underlying the possible role of JAK1 inhibitors prospectively in clinical practice.
Before, Herbert, you get to your questions, just a reminder to everyone at home that you can get involved in this conversation by using the Q&A tool under the video if you want to respond to any of Britta's observations from yesterday. I know steroids was a big topic last year. Herbert.
Thank you very much, Britta. So let me come back to vaccination, because it's a big issue for patients. They're coming and asking, and what should we say? I mean, I think the infliximab message is a very good one for the patients. I mean, the third shot will take place anyway in most countries, I believe. So let's come to other drugs. Azathioprine, what's the message to the patient? I mean, of course, much less data.
Much less data. I think we have data from previous vaccinations. And we know that azathioprine alone is affecting the response as well. And probably the strongest limitation we will have in patients on combination therapy. So being on anti-TNF and azathioprine is probably going to be a problem. But I think the key question always is, how do we monitor this, right? And what is the titer telling us? And I think this is the thing which is really, we don't know at the moment.
Unsolved yet.
It's unsolved. Everybody is measuring titers, and everybody's proud if he or she has a good titer. Still, we don't know what the titer really means. So this is up for discussion in my eyes.
Hopefully we will learn that soon, because at the moment we do not know exactly what to tell the patient.
Exactly.
So oral drugs, I mean, we didn't have new oral drugs for decades in IBD. Now they are coming, and initially we were rather concerned that it might take quite long that they work. But now we see excellent data that they work quickly, because people thought, yes, biologics, intravenous, subcutaneous, that's something you need to get a quick improvement. But it looks like the oral drugs are doing very well with respect to that.
Yeah, I think that's I think that's really good news, because you need to tell it, once you start a treatment for the patient, you need to tell them when to expect to get better, right? And for the anti-TNFs, we can tell them you will feel very soon. For Vedo, we are always a little bit more hesitant, although the data we've seen this year show that Vedo can act actually pretty fast as well. But I think 2 weeks for UPA and Filgo is a very good time frame. And we see an increase again over the first 8 weeks, but I think first signal in the right direction we get early on.
So this will change clinical practice. I mean, we will have those drugs maybe in the near future available in Europe. And then, I mean, patients are asking, what's the best drug for me? And many patients like oral drugs.
Many patients like oral drugs. It's a one daily. Filgo and UPA are once daily. I think that's clearly an advantage. Still, the price will play a role in clinical practice for most of the countries.
Yeah. But anyway,
yes,
we will treat and use oral drugs in the very near future again.
Yeah.
And of course, with azathioprine, we all know that it takes so long, and this was always so difficult to convince the patient. So would you expect personally azathioprine is gone?
I think azathioprine as a monotherapy is getting less and less, and I think that's what we've all been experiencing. Still, I think the role for azathioprine at the moment is as a combination of therapy, in particular when we introduce TNF antibodies. I think we will still use them, at least for the first year.
Okay, Britta, thanks very much. Magnus, over to you. It's UEG Secretary General. You've sort of been very intimate with this program. Can you tell us how it's changed over the last while since your chairmanship?
I mean, UEG Week is constantly improving, and I think always the latest meeting is always the best one. We are constantly striving to improve the format, to come up with new format, keep some of the old formats that are good and get rid of the other ones. So I think this meeting is the best one, obviously, and there are some new formats. This is a new format, for instance, that we introduced last year, to have some summary sessions where we discuss highlights of the day. This year we have the gut talks, we have the case closed, we have the experts on course. So there are constantly new formats. So and next year it will be even better. That's very magnanimous of you, as former chair of the scientific program, to say this year is the best. Yeah, but the next year will be even better. Indeed. So take me through your highlights, presumably looking at functional disorders. Yeah, that's true. I mean, there was a lot of interesting abstracts on functional gastrointestinal disorders and neurogastroenterology, and I picked a few of them. Most of them coming from one session focusing on dyspepsia and gastroparesis, which was a very nice session with 5 top abstracts. So I can start with the first one, which is relating to what Mario talked about, the management of dyspepsia, and here's focusing on management of functional dyspepsia. And this was based on expert opinion. So this was using a Delphi approach, asking experts how they manage functional dyspepsia. And when it comes to diagnostic approach, they used the Helicobacter pylori testing as the first step. And many of them also used upper endoscopy and abdominal ultrasound early on, which you can debate whether that is correct to include both of those. But in most patients, they do that. They use that. If there are risk factors and high age, they use upper endoscopy in all patients and often add CT imaging as well. Celiac serology is used selectively when there is weight loss. Gastric emptying test also quite selectively, only when there is nausea and vomiting at the same time. When it comes to treatment, everyone uses Helicobacter pylori eradication if Helicobacter pylori is there. And then there is a difference between different symptom profiles. So if you have more pain, there is a different approach compared to if you have more discomfort, postprandial fullness, etc., then you use other drugs. So PPIs are often the first treatment choice for patients with pain, whereas diet, prokinetics, and PPI are used for patients with more discomfort, the postprandial distress syndrome. We frequently use neuromodulators as well, but that's more second or third line treatment options. And there is also a little bit different when it comes to what type of symptoms you have. So if you have postprandial distress syndrome with more discomfort, you use mirtazapine, buspirone, for instance, whereas if you have pain, you use more tricyclic antidepressants. So these, what you can call experience-based guidelines, differ a little bit from the consensus European guidelines on functional dyspepsia was recently published. So that was quite interesting to hear that. And in the same session, there was also two other nice functional dyspepsia abstracts, also from the Leuven group, which is very active in functional dyspepsia. The first one was presented by Lucas Wouters, relating to the duodenal microbiome and its effect in functional dyspepsia. We have a lot of studies on the large bowel microbiome in IBS, but now there are also more and more coming when it comes to upper GI symptoms. And there was indeed a difference in the duodenal microbiome composition in patients with functional dyspepsia compared with healthy controls. That was only in the lumen, but not in the mucosa. There was a link with the symptom pattern, but this was unrelated to the clinical effect of a PPI. So probably the microbiome might also play a role here, and maybe also a target for treatment. The third the functional dyspepsia abstract from the Leuven group focused on the diet. There are surprisingly few studies on dietary interventions in functional dyspepsia. I mean, thinking about that, it is defined based on meal-related symptoms, and despite that, we have very few studies on the role of dietary intervention. So what they used here was a low FODMAP diet, which is a very popular diet for IBS, where you exclude carbohydrates that are poorly absorbed in the gastrointestinal tract. But here it was used to treat upper GI symptoms, the low FODMAP diet. And they used an open label treatment phase where 62% responded. And then they had a blinded reintroductions of the different FODMAPs. So they challenged them with different FODMAPs in powders to see whether that can trigger their symptoms. And many of the FODMAPs actually triggered their symptoms, especially mannitol and galacto-oligosaccharides. So it seems to be able to, I mean, they seem to be able to improve some of the symptoms by reducing these carbohydrates also. And when it comes to mechanisms, because it's not so obvious how FODMAP that may have their effect lower in the GI tract can influence symptoms in the upper GI tract. They show that they actually restored the mucosal integrity in those patients who responded well. So that was quite interesting. So we need more dietary studies in functional dyspepsia, but I think that was quite interesting. The second part of that session focused on gastroparesis, which is a combination of symptoms, predominantly nausea, vomiting, and delayed gastric emptying, but in absence of a mechanical obstruction. The first one was from France. Guillaume Gorcerol from Rouen presented data on the prognosis in patients with gastroparesis. So they used a big database that they have in France, in Rouen, where they included a little bit more than 1,500 patients who have undergone a gastric emptying test. And they divided the group then into those with delayed gastric emptying and normal gastric emptying. And having delayed gastric emptying was actually associated with increased mortality, with a hazard ratio of 1.87, so roughly double the risk of dying if you have delayed gastric emptying compared to not having delayed gastric emptying. And this was independent of diabetes, age, body mass index, so related to gastroparesis per se. But the mechanism is unclear, of course, because the cause of death was similar in both groups, cardiovascular and cancer. And finally, from that session, I think the highlight, one of the highlight abstracts of this meeting, which was the use of endoscopic pyloromyotomy, gastric poem, in patients with severe refractory gastroparesis. It was from Ratislav Hustak and co-workers in Czech Republic and Slovakia. And the background here is that when you think about gastroparesis, pylorospasm is considered to potentially play a role. So therefore, it's quite logical that you can use gastric poem to cut the muscle in the pylorus and see whether the stomach can empty better after that. There are some clinical case series, but this is a randomized controlled trial where they randomize the patients to receive the gastric poem or a sham procedure where they use the endoflip to measure the distensibility of the pylorus. And they plan to include 86 patients, but they also planned an interim analysis after 40% of the patients had been included. And when doing that interim analysis, the data and the safety management board said that we have to interrupt the trial because the effect is so much better in the gastric poem group compared to the sham.
Great.
Actually, the outcome at 6 months was met by 70% in the gastric poem group compared to 16% in the sham group. So quite a substantial improvement.
That's great, yeah.
Yeah, very good. And the gastric emptying improved, etc. And what was quite interesting also was that they were similarly effective regardless of the etiology to the gastroparesis. So I think this is something that we really look forward to, how this can improve symptoms for these patients. But it, of course, needs to be repeated by other groups and also compared with other treatments.
That's what you want when you design a trial, isn't it? So your comments, please, through the Q&A tool, Herbert.
Well, so gastric poem, that sounds fantastic. Any caveats from your side, or I mean, those data are.
Yeah, if I'm a little bit critical, of course, it's almost too good to be true. I mean, in our field, we are used to having, that's 10% better than placebo or 15%. Here we have 70% versus 16%, and also. It has been difficult to really show a clear association between the rate of gastric emptying and the symptoms. So, therefore, there must be something else here. And maybe I would pause.
May I ask you first, inclusion of patients? So, of course, only patients with gastroparesis. How were they defined?
They were defined as refractory to. I mean, they shouldn't respond to the standard therapies with prokinetics. But otherwise, they included all the different subtypes: diabetes, idiopathic, post-surgical gastroparesis.
Mario, you're an endoscopist. What's your opinion on that?
Yeah, I think this. Well, as probably all functional diseases are actually interesting because an holistic approach probably it's there, and one of the things that we cannot understand sometimes is even the patient. So how to classify the patients, and then we see relations that we can not completely understand because probably the symptoms that the patients are complaining we classify them as dyspepsia, but probably they are not. But coming back to GPOM, it's quite attractive. Of course, we need to wait for the long-term results because eventually this also leads to. I don't know what
6 months.
6 months.
So it's quite. But still.
Yeah. So
life is longer
may be
than 6
transient,
months.
but it makes sense. It makes sense. Well, it's quite slightly different for achalasia, but it makes sense. Yeah. But on the other side, and it was a sham. It was the randomized trial that we were waiting for. Yeah. So it's there. It's there. I think it should be used as. Well, as all the other strategies, of course, to listen to the patient and to allocate GPOM eventually.
So is it technically easy, feasible? Complication rate might be expected low, or what's your opinion on that?
I'm not an expert in both, neither POM nor GPOM, but eventually GPOM are for those used to do actually ESD or even POM. It will be easier, and the complication rate is it's manageable, I would say. And it's interesting coming from, actually, I do believe that we will see one on Tuesday. Yeah. So it's also eventually important to make the bridge between what is being said in one abstract on one session and the live demo on Tuesday.
Yeah. Nice.
So, Magnus, could it be that they had also included patients with functional dyspepsia, or
this is a big,
not so easy always to diagnose exactly?
Yeah. I mean, they had to have delayed gastric emptying, of course, but of course, I mean, there is a debate how to divide functional dyspepsia because some of the patients with functional dyspepsia also have delayed gastric emptying. So there is a debate. What is functional dyspepsia with delayed gastric emptying as opposed to gastroparesis, but that takes a long time to go into that. But you're sure. I mean, patient selection is crucial in these studies, of course.
Yeah, but if I may, before I alluded also to the role of scoping, and of course the experts scope more when there is alarm symptoms, even though we know that the predictive value is so low. But I don't know if you want to comment on your manuscript that you just recently published on better educating patients, and then that precludes endoscopy.
True. Actually, what we did is that we asked patients with functional dyspepsia who were referred by general practitioners for a gastroscopy, whether we would, and then we randomized them between informing the patients using eHealth about the merits of gastroscopy in functional dyspepsia, or we let them go to gastroscopy. And if you inform patients and tell them where the procedure is all about, you see an enormous drop of patients out of endoscopy. And needless to say that endoscopy in these patients doesn't give you any yield diagnostically.
Yeah, I know that this, of course, it may be correlated also with the prevalence of cancer, but I think this is important. Of course, I'm summarizing endoscopy, but it's not because you don't allocate patients to endoscopy that you are not an endoscopist. It's
Joost, good morning and welcome to the live TV studio. We met last year, of course, through the lens. You, of course, are the editor-in-chief of the scientific journal of UEG. You see all of these extracts and these top papers. What do you think of this year's programs, the sort of science we're seeing over these 3 days?
Well, the science that I see is getting better and better, well, like everybody says here, but it's really showing a difference if you compare the science now and let's go back for 4 or 5 years. In particular for the journal, I see that the papers that I get are increasingly better methodology. People reach out to other collaborators from different countries, so they tap into the network that develop here at UEG, so you get multinational, international collaborations, and I think that will give you better studies because they are more definitive and they really are able to change clinical practice, and that's really something that I want for the journal.
Yeah, for sure. Your area of interest is liver and HPB. Can you take us through some of your picks from yesterday, please?
Well, I have a broader scope, so I went through the program yesterday, and I went to various sessions, of course. And one of the sessions that I really liked was on diagnosis, and the diagnosis for Crohn's disease, as Britta can attest, is sometimes very difficult. So people from the United Kingdom took the approach seeing methylation changes in DNA of patients with a suspicion of Crohn's disease. And they actually used a tool, an EPIC tool, in order to find these changes. And what happened is that they, with only 4 probes, were able to find a difference between patients with Crohn's disease and patients who did not have Crohn's disease. So it is a very nice diagnostic tool, and you only need to spit in a tube in order to get the diagnosis. So I think there is some room for improvement, and I think that if they will do a re-study and replicate the findings, that is probably ready for prime time. Another nice development was the use of genetic tools in order to make differentiation between various forms of microscopic colitis. You know, Jonathan, I mean, in clinical practice, we use different tools in order to make a difference on the patient, whether the diagnosis is X or Y. We combine endoscopy findings, pathology findings, we question the patients. But this study really made a difference. And the authors actually used a genomic-wide association study. So they scanned the whole genome of patients with microscopic colitis, collagenic colitis, and lymphocytic colitis, and they started to see differences. And that is really where it starts to getting very interesting for us. For example, for collagenic colitis, they were able to find a signal at chromosome 6 at the HLA, while for lymphocytic colitis, they were not able to find that. So that really separates both disorders because, and that's very important because in the clinic we think they are more or less of the same, but they have a different pathogenesis, and that was absolutely really, really stunning. I thought this is the direction where we actually are going. Another thing which I thought was interesting, I mean, I'm a gastroenterologist, but I also like to do endoscopy, so that's where Mario comes in. I mean, Benjamin Walter is a German endoscopist, and he did a field study where he was questioning his colleagues, actually, a number of colleagues who were also doing endoscopy, about musculoskeletal pain, whether they feel pain somewhere in the body because of the endoscopy. And actually, that was true. 70% of our colleagues really feel pain in the neck, in the back, in the thumb, and they need to reduce the number of hours that they put into endoscopy. So maybe that's a German thing. I don't know, Mario.
No, it's probably not. And I think this is quite relevant. I think we all look at biomarkers and AI for imaging, and sometimes we forgot this kind of, well, this is not referring to non-technical skills, but also to the way we organize the unit and to the way we organize the room and to the way we teach how to do endoscopy. So I think this is actually, there are some societies pushing curriculum for ergonomics, so how to adhere to recommendations of where to put the screen, where you should stand up, where the patient should be, where the scope should be, because otherwise you repeat. So if you are a tennis player and you choose a racket that is different from 5 grams only, and you say, well, why 5 grams is different? And then you realize that you use it several times during a game. So if you think about the scope and then you put all your jackets and it's important. Ergonomics, of course it's obvious, but nobody cared. I think nobody's caring clearly. Yeah, and when you teach, I think you should probably start also by that.
True, and I see more studies coming up also for the journal, and I think because these complaints lead to dropout of very well experienced gastroenterologists, I mean, that's a loss for our profession.
And eventually for missing, because then you get tired and you get, well.
So, I mean, in the middle of a surgery, would that discomfort, like, would that ever, is there any evidence to suggest that might affect the treatment of a patient?
I don't think, well, I think for those kind of things, we probably don't need evidence. Yeah, to think that if you are tired, you behave, or you may lead to a bad outcome. It's not measured, as far as I know. But it's a problem for the doctors, and it may result in a problem for the system and also for the patients finally.
Probably hard to measure anyway, to get a doctor to say, I messed up because my fingers hurt.
There are things that probably,
Today is International Doctors' Day.
Ah, yes, Katerina has gotten in touch saying, good morning, everyone. Today is International Doctors' Day. Did you all know this?
No.
Ah, okay. Well, congratulations, and I hope celebrate that, although we're celebrating with this discussion in a way. Herbert, did you have a question?
No, maybe
yes. Over to you, back to you, Joost.
Yeah. On the therapeutic side of the story, there was a very interesting abstract on the artificial pancreas. You should know that if a patient has pancreatic cancer and you go for a total pancreatectomy, you get brittle diabetes in return. Brittle means you cannot treat these patients adequately with insulin. So the sugars go all the way up and down. So it's very difficult to manage. And a guy actually from the Amsterdam area, he invented a artificial pancreas that you can actually put on your stomach, and it goes with 2 needles, injecting glucagon and insulin, and it really calibrates the sugar levels in the blood. So these researchers actually tested 10 patients and see whether they were in the margins of acceptability with respect to these sugar levels. And that was actually the case. So I think that for these patients with brittle diabetes after a total pancreatectomy, this is really a good outcome, and this is going to be a solution for these patients. So that was a very nice development.
So that's not just diagnosis of the sugar levels, that's actually modulating the sugar levels in real time. Yeah.
So you're injecting insulin, you're injecting glucagon in order to balance it off, and that is really making a difference for the life of these patients. So that was a very interesting development. And then what I always like is that young people enter the arena. And Tim van Uitsel, he is a medical student from the Catholic University in Leuven. He did a very nice study with Van der Merwe in the endoscopy unit, where they were seeing patients with gastric obstruction due to mostly pancreatic cancer, where also the biliary tract was obstructed, and patients had jaundice. Normally, you refer these patients to surgery for a surgical procedure, but patients take a long time to recover from such a procedure, and it's not always successful. So they tried an endoscopy approach with EUS, and that was really successful. In the, let's say, 20 patients they actually did, compare that to historical controls. And patients had less time in hospital, recovered better, and had a better outcome. So I think this is a very nice approach and needs to be developed further.
I think we should have gotten Leuven to advertise on this particular segment. We've mentioned so many of their work, and it's highlights of yesterday. Some great work there.
Yeah, but may I?
Please.
No, this is interesting because on the same late-breaking abstracts, there was also a multi-center trial study. coming from or led by a Dutch group, but with at least with Italy, as far as I remember, and they compared also US approach with the gastroenterostomy versus stenting for these kind of patients, and they showed that there is a way there rather than sticking with the stent. So I think it's US is let's say disrupting also again and again our field.
So Jos, can you explain briefly what they did with regarding the EUS, which procedure exactly was performed?
Yeah, true. They connected the stomach with the jejunum and found a way through, and also connected the bile ducts to the jejunum. So they really, well, that's a very cool approach, I think. And of course, you need endoscopy experience to do so. But for patients in that phase of their life, it really makes a difference.
There may be a subgroup of patients where, with ascites, that may preclude the US, but in some centers they drain the ascites and then they place they construct the anastomosis. And of course, the learning curve for this procedure has been one of the challenges, but more and more centers are doing it. So I would say that it will challenge our field.
So it's the way interventional endoscopy is going, I mean, to the benefit of the patient. And I think that's the importance of scientific contributions in such a meeting, that physicians recognize that's the future.
And I think, I mean, testament to that is that we should leave a diagnostic endoscopy, for example, for functional dyspepsia, and really go into this direction where we as gastroenterologists can make a difference.
Yeah, I totally agree. I mean, that's all our ambition, and we have to go for this. So, Josta, one more question to the methylation study. They just took a simple blood sample, or what have they done?
No, they did a spit test. So they used saliva from patients. And they went for methylation of DNA, and they did a very broad study with hundreds of probes. And then after selecting the probes, they went back to 100, 20, 10, and 4 probes. And they think they can bring it even narrower to than 4 probes. So I think this is a very nice way of taking this diagnostic process into account.
Any interpretation, methylation of what is going on? Do we know more or not yet?
Yeah, they went to the databases of patients with Crohn's disease and where GWAS were done, and they were looking to the Crohn's loci in order to see whether that actually has pathogenic implications that I'm not sure of. Another study that I like to highlight, what I always find interesting is studies where you do predictions, and in particular for mortality. And I think that I would like to highlight 2 studies briefly. First, a study from France where they surveyed patients with gastroparesis. And indeed, gastroparesis has an increased risk of mortality. That was new to me, but I think that is quite interesting. And a second study from England showing that in patients with liver cirrhosis who have hepatic encephalopathy, they have an increased risk of dying. But if you gave these patients rifaximin, then they survive longer. And I think that's a very nice token of knowledge.
Herbert, thanks very much for that, Joost. Herbert, I know you had a study that you wanted to highlight if we had time. Maybe you might tell us what your pick from yesterday was.
Yeah, I picked one presentation which was on celiac disease. We heard yesterday morning, nice in the opening session. It's a very common disease. 1 to 3% of the population, no therapy available, only diet, it's a young population, so it's very tough. And Detlef Schupan reported his phase 2 study where they used so-called transglutaminase 2 inhibitors. So transglutaminase plays a major role in the pathophysiology of the disease, and they developed now inhibitors. So it's a phase 2 study. It has also been published in the New England Journal of Medicine now. And I think it's an interesting approach because they used 3 dose levels and a placebo group and treated for 6 weeks and could show benefit for the patient, but especially they could reduce bowel damage. So, I mean, there are several things now going on in celiac disease, and I think it's very important because the patients are struggling for therapies to improve their life quality, and it's a good example where the direction could go. So let's see how phase 3 studies will look like. But I think it's a very attractive, interesting approach.
It's an interesting one because the treatment is really clear, but it's very difficult to adhere to, as we've seen.
And we have heard yesterday 40 to 50% are not able to adhere. So they need something.
Yeah.
And they need a therapy. So we have to do everything developing into this direction of therapies.
I mean, just very briefly, are there other GI diseases that have such a clear-cut answer that isn't very workable?
It's probably a prototypic example where we know exactly where it starts and what are the consequences. So hopefully we'll find better solutions in the near future.
Yes, very good. I really enjoyed that. I hope you did too. This was our UEG Week Digested, where we looked at our favourite picks. We'll be doing this again tomorrow morning at 8 a.m. here in the Vienna studio. Thank you so much to our wonderful faculty for their observations and taking time to comb through that programme. If you liked any of those sessions, you can go back and watch them just a short time after they've actually been aired. You can find them in the Missed Session section of our website. Coming up here live in studio, Case Closed, another examination of some tricky cases at 12, and then we have Gut Talk, lessons learned at 3 p.m. And then this evening at 6 p.m, the Research Prize session. It's going to be fantastic. Don't miss it. Well, we'll be giving our Research Prize for this year, and we're going to finish off then with the UEG Week Tonight Show with the Best Journal Prize at 7. Enjoy the day, explore the platform, engage with the faculty speakers, and engage with each other. Enjoy your day. We'll see you back here at 12.